Hi, this is Jeff Lighthall from Critical Care. This is the first of two videos on managing the unstable patient. Second video will talk about how to take care of patients with respiratory distress, and this one will talk about taking care of patients who have hemodynamic instability. The background of this talk is the video on the pathophysiology of shock states, so please watch that one first if you can. And this video will cover a selection of vasoactive medications for patients with hemodynamic instability. I also encourage you to watch titles on fluid management and evaluation of shock states. Specifically, does patient need a vasopressor or an inotrope? The treatment of any patient in shock or with significant instability proceeds along two different limbs. One is taking care of the underlying cause, whether it's a heart attack or a bleed requiring surgery or IR, and then the other is resuscitation, and that's the subject here. So, when taking a look at your patient, you're going to be using tools such as echo, physical exam, art line trends, art line respiration patterns, responses to leg lifts and blood pressure and art line waves, as well as CVP morphology and trends, is anything you get your hands on. And what you're trying to figure out is, what's the patient's inotropic state? How is contractility? Is the heart beating pretty nicely? Is it handling the volume that's inside the heart? Or does it look like it needs an inotrope? You don't have to take a look at too many views to figure this out. Just a good view of the LV and the RV, whatever you can get. You also want to know what the vascular tone is like. And some of this is kind of a guesstimation. So for example, if you know that the patient's having an allergic reaction and they're very warm with good cap refill, but the blood pressure is terrible, that's a pretty good indication that they have low vascular tone. Sometimes it's a finding by exclusion. So if you've given the patient a bunch of fluids and their contractility looks okay and their blood pressure still is terrible, well, that's probably a vascular tone problem, if not a bleed. So that's kind of how you triangulate it on that problem. And then finally, you want to figure out whether they have a cardiac output that's responsive to fluid. Accordingly, you're basically going to be using three tools to assess the patient. One is fluids, one is inotropes, and the other is vasoconstrictors. And so just figure out what the patient needs, and these will be your tools. Now there's some fine-tuning as far as what kind of inotropes and vasoconstrictors to use, and that'll be the subject that comes up next. So the way I like to think about resuscitation is, think about it as this door that kind of stands between you and getting to the other side, and the other side is saving your patients. And so there are two keys or two locks that are keeping that door shut. One is fluids and one is medications. And so if you can figure out whether they need fluids, then that takes care of that lock right there. And then finally, you have to figure out what medications are going to open the door. And I'd like to think about this keyhole as having three different dimensions. And so one's going to be heart rate, one's going to be contractility or inotropic function, and the final one is going to be vascular tone. So if you can characterize whatever kind of patient emergency or shock state you have along these lines here and individualize those to your patient, you will find the right medication for that patient. So let's take, for example, a young patient who has say a mean pressure of 45. You give them 2 to 2.5 liters of fluid, you get up to 50. Still the patient's pretty darn warm, feels pretty dilated. You take a look at his heart with the echo, it is absolutely cranking away. He probably has a cardiac output at 20. And so when you take a look at this patient, and his heart rate, let's say, is like 95 to 100. So is there a heart rate problem? Absolutely not. Is there anything Is there any problem on the contractility dimension? Absolutely not. So what's his problem? Systemic vascular resistance. Okay, so that is your keyhole shape. What keys do you have that fit into that? Well, we have these medicines that only work in that dimension. These are things like vasopressin, phenylephrine, and norepinephrine. Norepinephrine obviously has a little bit of a heart rate and contractility shape as well, But you get the idea that something like epinephrine probably would not be an appropriate choice for this patient. It has a lot of effects on contractility and heart rate. Yeah, it works on vascular tone as well, but you're probably going to get tons of arrhythmias and other extra focus on the heart that you just do not need in this patient here. All right, we'll consider another example. Let's say you have a patient who you think has a pretty significant infection. You're taking care of that with antibiotics. You've given a modest amount of fluids. You take a look at the echo and you see a heart rate of about 65, and you see kind of a global depressed LV function, maybe an EF of 35, 40%. And so you have some problems there, or just not up to keeping the patient alive. And again, the map is 55 here. You want it higher. And so by physical exam and just clinical sense, you also know that the patient has a low vascular tone, or at least you surmise that. And so now your keyhole is slightly different. You've picked up some problems along the dimensions of contractility as well as vascular tone. It's just not purely a vascular tone problem. And so in that case, the keys that you want to use are those that not only provide you some alpha effects, but also those that do support contractility and to a degree some heart rate as well. And so these would be medicines like dopamine, epinephrine, or you might be able to get away with norepinephrine here if you have kind of a predominantly vascular tone problem. Sometimes that can support contractility and heart rate enough that you can do okay with that. I've tried to present an example here where maybe something like epi would be a better choice. So again, anytime you make a choice, you're going to go back and try to figure out how you're doing with your initial problem. So yeah, you've cured the blood pressure, that's fine, but go back and look at oxygen delivery. Does it look like that's any better? Or is your acidosis getting worse? Is your lactemia getting worse? Those will be some of the ways that you could figure out some of these choices. But I mean, here, this is somebody that clearly needs something that improves vascular tone and that also helps with contractility and to some degree helps with heart rate. Now, would dobutamine be a good choice here? Certainly a good inotrope, but it's an inodilator, right? And so that's not going to work very well here on the vascular tone front. In fact, it's going to make it worse. And in fact, that might actually starve the heart of even more oxygen and might make its function worse over time. So consider one more patient here. And here's a patient who really does not feel very well at all. They are having some mental status changes. You notice their urine output's dropping. You take a look at the patient, you see pretty prominent jugular veins looking at you. The patient's cold. Cap refill is very slow. Oops, sorry for crossing it out. But the blood pressure is basically, within acceptable range, and the heart rate is 82. So if you characterize this patient's problem, probably vascular tone is sky high, and that's what's keeping the patient alive. What is likely happening is that the contractility is really suffering and probably does not have very good heart function and probably not so much a heart rate problem. And so you look at the echo, and sure enough, you see a very globally depressed LV. RV is not horrible, but also depressed as well. And so fluid status is fine. Patient's heart is plenty full of fluid, but really what it's suffering from is contractility. And so here you've got a number of medicines that can actually improve your contractility. We've covered already epi and dopamine. Mentioned dobutamine obliquely. And then this does not look like dobutamine. And then finally there's milrinone. And so these are inodilators, which will help this patient by lowering some of the vascular tone, which is probably manifest by the very slow cap refill and just cold appearance. And so if you get rid of some of the compensatory vascular tone and at the same time support contractility, you'll probably break even with the same blood pressure, but you'll have a better blend of cardiac output and SVR, and thereby you'll actually have much more improved oxygen delivery, and all your end organs are going to function a whole lot better. Talked about inoconstrictors earlier. Here you don't need an inoconstrictor because that's a redundant mechanism. You've already probably have vascular tone that's sky high. You do not need to improve that at all. And so in these cases, if you've got an acceptable blood pressure, you can get away with using an inodilator. If your blood pressure was worse, say 50 or so, then you would not get away with an inodilator right now. You might kind of resuscitate the patient and get the heart functioning a little bit better again, where you can give that down the line, but that's probably going to be several hours and not now. Again, you want to make sure that you're maintaining a reasonable blood pressure at the same time you're improving oxygen delivery in your patient. And so you can't just completely focus on what's good for the heart at a given moment because, unless you're like seconds from going to a cath lab and treating the underlying cause, because really you got to keep the heart alive and the whole body alive. And sometimes, it seems a little heretical to get to, improve the vascular tone, but if not, they're just going to be dying very, very quickly. So this illustrates, hopefully, some of the decisions that you might have to make between inoconstrictors and inodilators. So a couple of final thoughts. First, all of these are very dynamic situations that we're talking about here. And so your contractility can actually look good one day and on the next be poor. And so this can change precipitously over the course of a few hours sometimes. Septic patients can get myocardial depression, and then some patients who've been hypotensive for a while, when you finally restore their blood pressure, it turns out to be that their heart works a whole lot better. And so someone who might look like they need an inotrope one moment might not a few hours later, and vice versa. And again, as you treat the underlying cause, your vascular tone might improve. And again, it might also decrease as the patient warms up, as they get new fevers, etc. And then fluids, you can resuscitate a patient pretty nicely one moment, but chances are, even if you get a couple liters in, it looks like you've got them all tanked up. Over the next several hours, they probably will need another couple liters in small boluses along the way. You can have capillary leak. Sometimes patients even have recovered renal function, will pee the fluid out, and so on. And so these are kind of dynamic situations where the fluids are shifting around quite a bit. Now, you don't want to always give fluids, even though someone's responsive, because they might not be fluid tolerant at that point. But suffice it to say that once you've made some decisions based on someone who's euvolemic, that might not last forever, and you might have to give some more fluids back as you go. So as covered in a prior talk, really the key components of shock are ending up either on the bad part of the V.O2 DO2 curve, the so-called oxygen supply-demand relationship, or on the lower limb of the autoregulatory curve, which is basically the curve that describes the relationship between organ blood flow and mean pressure. And so if these are the roots of all evil, what you're trying to do with the fluids and the medications is actually getting to the normal parts of these curves. And I mention this here mainly to point out one error that can be made, and that is if you see somebody with a low blood pressure, most of the time you can give a host of vasoconstrictors in huge doses and actually normalize the blood pressure. But in doing so, you might actually have a reciprocal decrease in cardiac function, which will burn you here. Meaning, as you go this direction on the blood pressure curve, you might actually be heading in a dangerous direction in the supply-demand curve. So this illustrates the idea that anytime you perform an intervention, whether it's giving fluids, whether it's giving inotropes, dilators, constrictors, you name it, what you want to do is go back to where you were starting with on as far as blood pressure and as far as oxygen delivery, and just see, can you prove to yourself that you're going in the right direction? And really that's kind of the key point of resuscitating patients, is making sure that you're going in the right direction, literally the right, from left to right on both of these curves. And when you do feel like you have a blood pressure that's within what the patient's used to seeing, or even just a map of 65, and you know that some of your problems with oxygen delivery, whether it was lactemia or a low mixed venous O2 sat, or a wide anion gap, or a horrible metabolic acidosis, if that is all kind of normalizing and you feel that whole status is normal, then you're basically done. And you just have to find the medications or lack thereof that just help you maintain those states. So anyway, this concludes this kind of short module on selection of medications as you resuscitate patients. Hope it was helpful. Thanks for watching.